Welcome to this continuing education activity titled TNBC and Immunotherapy, Key Applications for Pathologists. In this activity, we will describe the role of PD-L1 testing in triple-negative breast cancer, or TNBC. We will discuss recent advances in neoadjuvant immunotherapy for patients with TNBC, and summarize how pathological response is assessed in patients with breast cancer who receive neoadjuvant therapy. At this time, I'd like the panelists to please introduce yourselves.
My name is Huina Zhang, and I'm a breast and a GYN pathologist at the University of Rochester Medical Center. And it's my pleasure to be here today and to share our institution's experience.
My name is Marilyn Rosa. I am a senior member at Moffitt Cancer Center and Research Institute in Tampa, Florida, and a professor of pathology at the University of South Florida. I am also the section head of breast pathology at Moffitt Cancer Center and the director of the Breast Pathology Fellowship.
I'm Lemi Said, the fresh graduate of the Breast Pathology Fellowship at Moffitt Cancer Center, where I also did a molecular pathology fellowship, and I'm glad to be here today. Thank you.
Please tell us when and how you perform PD-L1 testing in patients with advanced TNBC.
Before I start that, let me introduce our institution. The University of Rochester Medical Center is a large academic institution that's serving or serves a large population in upper state New York. So we have probably around like 10,000 surgical cases each year. And regarding the breast pathology, we have 8 breast pathologists and sending out about 5,000 in-house breast cases and additional 1,000 consult cases each year. So regarding the PD-L1 testing, first we perform it in-house, and it is request. We do it upon the clinical provider's request. The 22C3 is the only antibody we are doing in-house.
We perform it here at Moffitt. We don't send it out, and we already had it here because we were doing it already for other organ systems, so we didn't have to really bring it on board. It was already here. We just have to validate it for breast. So we are doing the test only upon request. We don't do it up front. So basically, we sign out the case and wait for the oncologist to request the test. Here we are currently 9 breast pathologists, and all of us are trained to interpret PD-L1.
Just like Dr. Rosa and Dr. Zhang mentioned, so far it has been by request, and it's the use of the IHC in detecting PD-L1. It's performed on routinely fixed, formalin-fixed paraffin-embedded tissue. However, at Moffitt Cancer Center, there is like a comment for decalcified specimens that it has not been validated on decalcified tissue, so the results need to be interpreted with caution. Otherwise, it can be performed on any paraffin-embedded tissue. Throughout my fellowship, I was trying to gather more and more information about PD-L1 testing and different practices, and it seems that it varies across the country. Even during a discussion of breast pathologist panelists where they were trying to discuss the PD-L1 testing in different institutions, you can see the differences. Some institutions send out all their testing. Some institutions perform similar testing where each pathologist is responsible for their case and specimen. However, some institutions designate a sole interpreter of PD-L1, and that would be the expert in that institute to read out all the PD-L1 testing. So you can see that the practice varies widely across.
Here, it depends on the setting. For neoadjuvant treatment, as you know, we really don't need to test. So they use the drug as the patient meets criteria that of triple negative cancer, early stage. So that one, we don't really have to worry about testing or anything. But then we have in the metastatic setting is when we really have to come into play for that decision. The oncologists usually try to do the testing in the metastasis. The only way or the only time we don't do it in that tissue is when there is not enough material or is an FNA or something, some tissue that doesn't really have the criteria for adequacy. that we know it should be at least 100 cells. So we go to the primary tumor to test it there.
I think our institution is a little bit interesting and also different from Dr. Rosa's institution. About 75% of the cases, the PD-L1 testing were done on the breast primary, and about then followed by the bone and soft tissue, and then lymph node and others like brain or lung or liver, they just account for a very small amount of cases. I think probably the patient has metastatic disease, and I don't remember we have any discussion regarding what material should be tested. It's basically requested by the clinical providers. Usually, if we look at the request and it seems reasonable, because we know the bone tissue has been validated, the PD-L1 testing, and also liver or organ. The liver usually metastatic doesn't have a lot of, the PD-L1 positivity is very low in the liver specimen. Once we see that, and we are going to talk with the clinician.
So again, being at a cancer center where you get to see different cases and different organ systems, you can appreciate that being in a certain subspecialty, you'll develop a certain sense of expertise in that field. So for example, with PD-L1 testing, it's all based on the difference in organ systems where you're going to use the TPS versus the CPS. And for example, in the breast, we're using the CPS with a different cutoff of more than 10% or less than 10%. So in that regard, it is crucial that you recognize the borderline cases, and it's very useful to show it to people of expertise in that field to see their opinion, because again, with the CPS scoring system, we're using not just the tumor cells that are staining, a membranous staining, but also the mononuclear inflammatory cells, and that's the macrophages as well as the lymphocytes that are staining, while that does not apply when you're using the TPS system. So that's very important to recognize what organ system you're dealing with and the cutoffs for that organ system as well. You need to always refer back to the manual. You always need to check. You need to check for changes as well that would arise with the new drugs introduction and the new clinical trials that are being published. So all that plays a part greatly in determining PD-L1 and the challenges associated with it.
On the inter-observer variations on the borderline cases, that is definitely a challenge. Most of the time, we have to look at very carefully, closely, and do the different quadrant counts and trying to get best estimates. We also sometimes we show to our colleague and show it at our consensus to get a consensus opinion. I think that's maybe the most challenging area. So regarding the metastatic tumor of unknown primary, because occasionally we do receive that cases and those cases, and we did a bunch of immunostats, but we still cannot get a definitive conclusion where the primary tumor is, and then, but we still get the clinical request for PD-L1 testing. So I think that's that's definitely a challenge to see which antibody we should order and what the criteria we should follow for the PD-L1 testing. So then that's usually based on the patient clinical history and also discussion with the clinical providers. It's a little bit challenging to differentiate the tumor cells from the background cells. So that's also a challenging, but when you look at it, the corresponding H&E slide, that's probably can help solve the problem.
So this is an example of a triple negative breast cancer that was requested for PD-L1 testing. And on the H&E, you can appreciate the higher grade of this cancer, which is the status for the triple negative in most cases. And with the PD-L1 testing, you can see that there is membranous staining that's staining the tumor cells as well as some of the inflammatory cells. And although the staining intensity is good in this case, in this example, it did not attain to the cutoff of 10 for the CPS in triple negative breast cancer. So that was an example of a PD-L1 testing that did not attain to the level cutoff of 10. And it's a good reminder that intensity does not play a major role in PD-L1 testing. We need to count all the cells that are staining membranously, regardless of its intensity.
Let's now review the results of the Keynote 522 study, which was the use of an immune checkpoint inhibitor, pembrolizumab, in patients who have early-stage triple-negative breast cancer. The results of the study were published in the New England Journal of Medicine in 2020. Patients with early-stage TNBC either received neoadjuvant pembrolizumab plus chemotherapy, followed by surgery and adjuvant pembrolizumab, or patients received neoadjuvant placebo plus chemotherapy, followed by surgery and adjuvant placebo. 64.8% patients in the pembrolizumab arm achieved pathological complete response at the time of surgery, compared to 51.2% in the placebo arm. So let's talk about the assessment of pathological complete response in breast cancer. How is this defined, and how do you perform this in your own institutions?
So as we know, the pathological complete response, the PCR, in the neoadjuvant breast cancer cases, there are multiple definitions has been used in the clinical trials. So here we can see the clinical trials, they use different PCR definitions, including the YPT0/TIS, YPN0, which means there should be no or absence of invasive carcinoma or cancer in the complete resect breast specimen and all sampled regional lymph nodes. So in this category, DCIS is allowed. This is the most commonly used in the clinical trial. And the YPT0/YN0, which is the absence of invasive and in situ cancer in the complete resect breast specimen and all sampled regional lymph node. The DCIS is not allowed. And the third one, which is YPT0/TIS, is absence of invasive carcinoma in the complete resect breast specimen, regardless of the DCIS or nodal involvement. So those are the three most commonly used PCR definitions. FDA working group did a study and published in 2014. So they found the YPT0/TIS or YPN0 or YPT0/YN0, they were better associated with improved event-free survival and overall survival. So they emphasize that persistent nodal involvement following neoadjuvant chemotherapy was associated with an increased risk of recurrence and death, and residual DCIS did not have prognostic value.
I remember when I trained as a fellow, there was not really like an accepted definition or for this, there were so many different systems that people were using to do this. And I trained in a way that we really didn't use any system. We just would say there is chemotherapy changes present, and there is a mild, moderate, or no response to the neoadjuvant treatment, or complete response to the neoadjuvant treatment if there was no residual tumor in the breast. But with the years, has become clear that we really have to do this a little bit more uniform, because it's not only important for the patient, but also important for clinical trials and for making sure that the data that we get from clinical trials and research purposes is correct. We really have to have a good communication with the clinical team to make sure that we are using the same criteria, and also to make sure that everything that we are including in our pathology reports is what they need to know for clinical purposes and for future inclusion in trials if necessary.
I agree that the achievement of the pathology complete response in the breast and the axilla correlates with improved survival, as have been shown by the studies. And also I would like to add that this correlation has been shown to be the greatest in triple-negative breast cancer, then followed by HER2-positive breast cancers, while patients with ER-positive breast cancers rarely achieve a PCR neoadjuvant endocrine therapy. Therefore, it is very important to assess, pathologically assess the breast and axillary nodes after surgery. And that is performed to determine the presence and the extent of the residual invasive disease after completion of neoadjuvant treatment. And being again at a cancer center, we have a lot of exposure to complex cases, even to the point where there will be multicentric disease or multifocal disease, and more than one tumor bed in this regard to be assessed. And that takes a lot of teamwork to assess it in an ideal way, starting from the imaging and the patient history, going into the gross examination, and then to be mapped, where a map is provided with each of those treated specimens to guide the pathologist while microscopically examining those cases. So it's a multi-step where it needs an extra effort made to achieve that ideal assessment of the specimen.
At Moffitt, about 40% of the cases that we have here have been already diagnosed in the community. Some of them have been treated in the community and have surgery in the community. They come here for follow-up, and then we get to review those cases. And my experience has been that community pathologists are not really using this degree of detail that academic institutions are doing, the degree of sampling and mapping and criteria that we do to establish a pathology complete response. And I think it's mostly due to the fact that many of them are doing general pathology, and also they don't have the tools and resources to do it, because every time I talk to them in a meeting or a presentation, they always say that they really don't have access to clinical history. They don't have access to radiology reports. They don't have access even to how many biopsies the patient have. So they're practically going to see the specimen blinded. They just know the patient had cancer, So without correlation with radiology, without then having like a faxitron to be able to x-ray the specimen and to see where are the clips, how many clips the patient have, what clip matches what tumor, or what clip was benign and what was malignant. It's very difficult for them to really do it.
Here, because we frequently received the outside consult cases, and I do notice that for the community hospital, usually don't provide those information. Sometimes if the patient is enrolled in our clinical trials and they do need the information, then we have to, whoever participates in the clinical trial have to interpret it. Yes, for our institution, since it is in our template, so we have to report on every neoadjuvant case. I think the most important thing for accessing the neoadjuvant cases, the first thing is you have to know the clinical history. But sometimes we really don't, although we recommend to our clinicians, please provide such information to us so we know, but sometimes we don't. For us, we usually go to the clinical. That's very easy, pretty easy for, I understand in some community hospital, maybe it's hard. And also we emphasized the gross examination, which is also important, like what Dr. Saeed mentioned. You have to correlate with the imaging, with the pre-treatment information, make sure that the tumor bed you sampled represents the tumor bed, and based on the recommendations, how many blocks are needed. But another thing I think I can recommend the pathologist, if they cannot get this information, look at when the biopsy was done. If the biopsy was done 3 months or more earlier, that triggers to think whether the patient received neoadjuvant or not.
All pathologists have one thing in common, and that's the thoroughness and accuracy in reporting. And I see that happening whether at a community-based or at an academic-based programs, where especially with the improvement of the electronic medical records, things are being more and more readily available for the pathologists to be used. So that's one thing that the pathologist can rely on. They can also look for a lot of helpful resources that are available online. For example, there is the residual cancer burden calculator that they can use. There is the CAP protocols that just recently added that RCB component with the option of reporting if the institution would like to report that. And it has all the parameters outlined. So the pathologist can really use that as a guide to check for each of those parameters and report them. And that would ultimately achieve that status of reporting accurately.
One of the things that I learned during my career is that communication is extremely important. So communication with the clinical team is going to save you from a lot of headaches. So if the clinical team is asking you for something that you don't understand and you cannot provide for any reason, just set a meeting with them and then discuss with them in person, first of all, what they want, how they want it and why they want it, and then what are the challenges that you have that you cannot provide that information at this point, or what do you need from them or from the institution that they give you so you can start providing that information to them. So when there is this communication, everybody can understand each other better, everybody can understand why a clinician is requesting this or that and why a pathologist is not able to provide that information. So this to me is number one. And number two is to train everybody that works with you. One of the first things I did here when we started doing this thorough examination of the breast post-neoadjuvant was when we enrolled in the I-SPY trial. We were trained. I was sure that all pathologists got the training, and then I got the PAs trained how we need to do these specimens. I got them access to the medical records. So now the PAs, every time they are going to gross a specimen, they know the MRI results and they know how big supposedly the tumor bed should be. So it's a guidance for them. They know how they should sample it and why. So it's much easier for us. So I think communication, training, and consistency are very important. And again, you have to know what the team that is working at your institution needs from you. That's the basic, because they may not need this thorough examination that we are doing. So, and you may not be able to provide it. So, but the communication, I think, is really, really important to keep the team working together for the benefit of the patient.
Definitely trying to discern DCIS, that's ductal carcinoma in situ, from residual invasive carcinoma is a very important step, because the presence of DCIS does not preclude PCR status. However, if there is any residual invasive or microinvasive carcinoma, that would be a status where there is residual cancer and it's not a PCR status anymore. So definitely the morphology with the microscopic examination is key, as well as the use of IHC, that's immunohistochemical stains, to discern the in situ component from the residual invasive component. And the same also applies to the lymph node examination, where it's very important to apply immunohistochemical stains, for example, cytokeratin, to try to find any, even if it's isolated tumor cells, because again, that precludes the status of a PCR.
Sometimes the tumor cells can be very scattered, and so you have to look at carefully corresponding with the growth findings. And another thing is regarding the isolated tumor cells in the lymph node.
We also have to, when we're evaluating the case, we have, sometimes there are changes in the tumor morphology. Sometimes, more often than not, that we really think it would happen, we have other cancers sitting in the breast that were not detected before, and then it doesn't, the fact that you found your poorly differentiated invasive ductal carcinoma doesn't mean that the patient cannot have a invasive lobular carcinoma in the background, which I have seen cases like that. myself. So it's we really have to be alert, and it's not something that we can look at low power only sometimes. One of the things that I find that we struggle a lot is the distinction of therapy changes in a small acini and dogs from the CIS, because sometimes the therapy changes can be really, really exaggerated, and then it's hard to tell, is this the CIS versus it's not the CIS. I understand that that really doesn't impact the PCR diagnosis, but it's something that people struggle, especially it's important if you are dealing with this close to a margin. Okay, so I have 4 pictures here just to show you. The upper 2 pictures are the same tumor. It's an invasive lobar carcinoma on the left. You see that this is a tumor that is basically mostly low grade. We know invasive lobar carcinomas don't respond that well to treatment, but still they receive neoadjuvant sometimes if there are metastases in the axillary lymph node, etc., different clinical reasons. And here we have the tumor post-treatment. When you see that the morphology have changed completely, now looks like an apocrine type of tumor, complete different morphology. So this can happen. So for somebody that doesn't have access to the core biopsy and you find something like this, it could be difficult to realize that you are dealing with the same tumors. If you see a report saying invasive lobar carcinoma grade 1, and then this is what you have in your case. So it's something that we should consider that could happen. And this one in the last 2 pictures at the bottom, on the left you have, this is completely benign atrophic acini. You can see the degree of pleomorphism that these ductal cells have based on the treatment changes. So it could be difficult to distinguish, but this one is a kind of an exaggerated therapy-related changes where you can see these monstrosities. It's very, very easy to identify as residual tumor, but the problem with cases like this is that if the pathologist doesn't have the information or doesn't know that this patient received neoadjuvant treatment and sees a tumor like this, it can go through a rabbit hole thinking what type of tumor I am dealing with, because this really doesn't look like breast cancer. It looks like some anaplastic tumor. So that's when you really have to have the history or just entertain the possibility that you are dealing with a tumor that has been treated. This image that I have here was just to show you the therapy changes that you can find in the breast. And if you know what you're looking for, it would be easier to find those things and not to get confused with benign breast tissue. That is something that happens sometimes when the sampling doesn't really show tumor, but it doesn't show tumor bed either. And it's just sclerotic breast tissue. The pathologist needs to notice that this is different, that maybe the true area of tumor was not sampled and you have to go back to the specimen to put through that area, and you may find tumor or you may find just tumor bed. So if you know what you're looking for, it's easier for you to deal with that. So here, this tumor, this picture top left shows the classical collection of foamy histiocytes here with some inflammatory cells in the background, some of them are single, the macrophages in the background, and some lymphocytes, and also myofibroblasts. Here in the top right, we have proliferation of fibroblasts, which could be very, very brisk and could cause problems with diagnosis, because it could look like a spindle background with, it could be like a metaplastic carcinoma, for example. So I have to be careful with that. Sometimes we need also to use immunostains in cases like this to make sure that all these ugly looking fibroblasts are not malignant or residual carcinoma. This one here is just showing a case that had residual DCIS, and the tumor bed shows the foamy histiocytes and inflammation, but also show the calcifications, because when you have a tumor that has calcification and the tumor melts away with treatment, the calcifications don't have a place to go, they will remain there. So this is something that the pathologist can use to find the tumor bed, the presence of calcifications. And this one is a case that is a little more subtle, but you can see all this elastosis that is kind of edema in the stroma. So this is another way you can find the tumor bed when you have these histologic findings. And also in this picture, you can see proliferation of small vessels. That is another thing that is a feature of a tumor bed.
So here is the growth exam. So basically, this is a case. Biopsy material showed the invasive ductal carcinoma and DCIS, histology grade 3, ER positive, PR negative, HER2 positive with KI about 30%, and the lymph node positive. So clinically, it was a stage 3A disease, and the patient was enrolled into the I-SPY trial. And here is the growth examination, which first you have to correlate with the imaging and also with your growth examination to find first trying to identify the tumor bed. And like this one, there is just irregular translucent fibrous tissue in the supposedly what the prior tumor was, and there's no mass forming lesion. And the same as what Dr. Rosa mentioned, here is this is what a tumor bed microscopically looked like. And it's just very loose or sometimes can be dense fibrous tissue without any normal breast or tissue. And here you can see a scattered lymphocytic and also macrophages and also some small vessel formation in the tumor bed. And this case, the DCIS is still present. The lymph node was negative. So this is a PCR case, YPTS and 0. And I have another example. This is another case, which is high grade ER negative, PR negative, HER2 positive with KI about 80%. And the lymph node was positive on the previous biopsy material. And the patient was stage 3B and received a new adjuvant chemotherapy. And here you can see there is a mass forming lesion. And then this one, you don't need to do an extensive sample, just follow what the working group recommendation and do the sampling. And here we can see the residual tumor cells. Again, we do the RCB score, and also the lymph node status is very, very important in the RCB classification. So this is the example of the residual tumor in the post-neoadjuvant specimen.
Thank you for joining us for this continuing education activity. Please be sure to complete the post-activity evaluation.